All right. Welcome everybody to the 80th session of virtual shadowing. Tonight we are doing a specialty spotlight in family medicine, and we are lucky to be joined tonight by Dr. Dan Septum, who is himself a family medicine physician and an associate professor and vice chair for education and family medicine at UT Southwestern. And so next slide, please. This is the virtual shadowing working group. On the left side, we see all the student working group members. And on the right-hand side, we see all of our physician faculty, including Dr. Fowler, Dr. Marchetti, Dr. Salazar, and Dr. Reno. And next slide, please. So upcoming sessions. In December, we do have 3 sessions. The first one is December 7th. It'll be Insight on Career in Medicine and the Administrative Side of Medicine. December 14th, we're going to have a specialty spotlight in PM&R. And December 21st, we're going to have a specialty spotlight in cardiology. So the remainder of the month, we are not going to have sessions as we will be on break. And so we will do the next slide now, please. And so we will have 2 question and answer sessions throughout the presentation. There's going to be one in the middle of the session and one at the very end. So be sure to put your questions in the chat, whether you're watching from Zoom or YouTube Live, so that we can answer your questions throughout the session. And I'm going to let Dr. Fowler give an announcement here.
Welcome, everybody. It's so good to have you again. This is our 80th session, if you can believe it. We've been at this for over 18 months. And we're here for you. You know, we don't charge. We put this out there because we know you need it. All of you here are here because you are planning a healthcare career of some sort, whether it's medical school, NP, PA, nursing school, medical assistant, radio tech, and so forth. And so we're putting these out there for you so you can get an idea of what it's like to have an experience, a career, a lifetime in a medical career of some sort. We're going to be here. We're planning to at least have over 100 lectures. We're booked out through March already. And so if you keep coming back, we're going to be here, but you got to keep coming back. So really invite you to come with us every week. It's always an adventure. Great to have all of our friends, Angela and Nate and all the rest who keep coming back week after week. So good to have you back. So in any case, do let you know again that we're going to take 2 weeks off in a row right at the end of December. And so we will have that posted just to let you know. Check in with the website, virtualshadowing.com. We have a wonderful guest this evening. He's a dear friend of mine. He and I work together on the admissions committee, and we're going to talk all about that in a little bit. So Cheyenne, would you introduce our terrific guest for this evening?
Yes, of course. So tonight, of course, we are joined by Dr. Dan Septum. And again, he is an associate professor and vice chair for education and family medicine at UT Southwestern Medical Center. And so he will go ahead and if I'll let him take it away from here.
Okay. Everybody hear me okay?
Yes.
All right. Well, thank you guys very much for inviting me to be part of this, and a warm welcome to everybody that's online with us this evening. So I guess, yeah, I'm just going to tell you my story and how I got to where I am and just kind of go from there. So I was born and raised in Richmond, Virginia. I actually grew up in a town a little bit south of Virginia, south of Richmond, called Chesterfield, kind of near Petersburg. And that's where I spent most of my formative years as a kid. Subsequently, I went to undergraduate at George Mason University in Fairfax. And then after that, I went to what was back then known as the Medical College of Virginia. It's since been renamed and subsumed by Virginia Commonwealth University. So now it's the VCU School of Medicine. And that's the image of the Egyptian building that's on campus there. When I was in medical school, I had opted to, well, you know, med school can be expensive, so I had to figure out a way to pay for med school, and I opted to get on a military scholarship, and so that's what I did. It's the HPSP program, the Health Profession Scholarship Program, and you can see there it pretty much paid for tuition, room and board, gave me a monthly living stipend, which pretty much paid the rent. did require some military training during summer breaks, 1 month. And then, of course, I had to serve in the military after residency. If any of you guys are finding yourself in a similar situation and you want to look at doing something like this, I put the web links out there for you to the various Army, Navy, and Air Force HPSP programs. I think for somebody who is relatively unattached and doesn't mind moving around, the military can be a good option to get med school paid for. It certainly helped me out a lot when I started residency, and I was actually getting paid in residency. It wasn't much, but it was all positive cash flow in, and I didn't have to worry about any sort of student loans or debts or anything like that. So that was absolute blessing. All right, moving on. So when I applied to residency as an HPSP student, you have a couple of options. You can go on and do a military residency, or you can be deferred out to the civilian match and do a civilian residency. And that's what happened to me. So I actually applied to try and get a military residency, and that didn't work out. So I then reapplied to the civilian match and matched at UT Health Science Center in San Antonio. And you can see the little picture of the Riverwalk there. Had a great time in San Antonio. The Air Force pretty much left me alone by the time, throughout my residency. I got sent like a quick letter every year that said, please sign this just to let us know you're still alive. And I have fond memories of meeting the other residents for drinks on the Riverwalk after clinic and stuff like that. So it was an enjoyable experience. And then, of course, after residency, I went back and did some time in the Air Force. My first duty station was at Tyndall Air Force Base in Florida. It's near Panama City Beach in Florida, which is known as a big spring break place. But anyways, I don't know if the base actually still exists much anymore. A couple of years ago, it was wiped out by a hurricane. I think they're trying to build it back, but I don't think it's gone back to the same state that it was before the hurricane. Spent 3 years there, and then both my kids were born in Panama City. And then after that, we got stationed in RAF Lakenheath, which is kind of northwest of Cambridge. Sorry, not northeast of Cambridge in England. And it's a fairly rural agricultural part of the UK, but had a good time there. Was able to travel around Europe a bunch because of that. And so that kind of brings me to what did I do in the Air Force? So, family medicine is a very malleable field, and you can do a lot of different things. So when I was in the Air Force, I actually didn't work as a strict family medicine doctor. I worked as a flight surgeon. And so some people are confused by the term. They go like, what's a flight surgeon? Do you do, surgery in the back of airplanes? And no, that's not what we did. So the term surgeon in the military is a holdover term from the days like the Civil War days, 1800s, when every physician in the military was a surgeon, because that's what happened. People got injured, and the only thing that you could do was pretty much amputate a limb. So that term is just a holdover, and it just means doctor, as it's used in the military sense. So what do flight surgeons do? They're basically just primary care physicians for people that fly. And we do all those things that you see as listed in there. We see patients at clinic. We take care of problems both acute and chronic, and annual physicals. And we also take care of the dependents of the air crew members. We also had the interesting job of overseeing all the occupational health and public health kind of issues on the base. We would do inspections at various different shops on the base. Like if there was a shop that did engine maintenance, it was our job to go there and go check that shop out and make sure they were following all sorts of OSHA regulations and that sort of stuff. We also oversaw the eating establishments on base from a public health standpoint. So I learned how to do like public health inspections on fast food joints. One time we actually had to close the officers club down. That wasn't really popular, but anyways, we did that. And then as a flight surgeon, you do get to go flying, and you fly in whatever aircraft your unit has assigned on the base. So I've actually flown in F-15s and F-16s, and I did get a ride in an old F-4, which is on the left-hand side of the slide one time. Flown in a bunch of air refueling jets, a bunch of cargo jets and stuff like that too. I did go. This might sound like bragging. I don't know. I did get the opportunity to go to airborne school and get shoved out of an airplane with the parachute. So that was kind of fun. And I so did all sorts of kind of interesting things in the military that I probably never get a chance to do again. So the question is, why do flight surgeons have to fly? Well, as a flight surgeon, you are one of the very few people on base that can actually basically what they call, like, take a pilot's wings, meaning that you can assign him a category where he can't actually fly. And as you might imagine, that can be very unpopular with pilots. They're type A, hard-driven people, and they want to be doing their job. And so if you want the pilots to trust you, you got to go see what their life is like, and you have to go fly with them to understand what they do. So when they come see you as a patient, you have some validity when you tell them, hey, dude, no, you can't go fly with whatever X condition it is that you have right now. That validity is important. Flight surgeons are also key on operational mission support. So whenever your unit gets deployed somewhere, you typically go with them. Deployments can be long, deployments can be short, depends on what the mission is. And then you get sent out on training missions as well, which are usually fairly short, maybe a week, 2 weeks, something like that. Flight surgeons are on the operational side of medicine. And so that means you travel a lot as a flight doc. I think most of the time when I was a flight surgeon, I was gone from home at least 2 weeks out of every quarter, which is kind of rough when you have two little kids, as you can see there on the little photo on the right-hand side. So anyways, so what is flight medicine and aerospace medicine? So flight medicine is a subset of occupational medicine. It's obviously an occupational medicine that focuses on people that fly, the performance of people involved in, as it says there, air, space travel, and operations. You get a lot of training in understanding the changes that happen in human physiology at altitude, and also understanding the challenge of the human-machine interface. Whenever there is a aircraft mishap, whether it be a commercial aviation mishap, like the recent incidents that happened with the Boeing 737 MAX, or a military incident, as occasionally happens when a military jet has an accident. There's always a flight surgeon on the investigation team trying to figure out what happened, and was there some issue with the way the pilot was interpreting the data that was presented before him from the aircraft, or his environment around him, and that sort of stuff. So what was a day like as a flight surgeon? Actually, it was, a normal day was pretty benign, not too thrilling. You had to go do PT, or physical training, in the morning, because you had to pass the physical fitness test in the military, so you always have to keep in shape. So get up in the morning and do that. Get to clinic about 8 o'clock. You might have 8, 9, 10 patients in clinic, combination of physicals, acute illnesses, colds and things like that need to be dealt with, or strains. You would go to lunch, get back, and in the afternoon you might have non-clinical duties, which would include all sorts of things like sometimes a pilot or aircrew member would get some sort of condition which was technically disqualifying, and you'd have to kind of get them a waiver if it was a waiverable condition, or work on kind of rehabbing them so they could get back to kind of a normal condition, and then write up a waiver saying that they had returned to kind of normal functioning. As I mentioned, you would do occupational health visits to various shops around the base, the engine shop, um, looking on the flight line, just different types of things. And then you had to keep your own training requirements up to date. In the military, there were lots of training requirements. There's all sorts of stuff from your own personal, like making sure you had all the required vaccines that you needed to deploy. And then whatever was required of you in terms of training for your airframe. So whatever jet you're flying in, there's usually some sort of training requirements that you have to keep up to date there. So and do all that sort of stuff. And then about 5 o'clock, you'd be done for the day, head home, do whatever you want to do after that sort of thing. One of the interesting things that happened to me as a flight surgeon is because the military only takes care of, well, I should rephrase that. In the active duty military, you generally just have young, healthy people, because if you're not young and healthy and you can't deploy, the military boards you out. So, you don't take care of many of those chronic disease conditions like, diabetes and heart disease and things like that. What I did get good at is doing a lot of musculoskeletal medicine, because as you might imagine, young people go out and they're involved in whatever sports or activities that they enjoy, and they injure themselves. And I did see some really strange things from time to time. When I was at Tyndall, there were lots of people that like to go fishing out in the Gulf of Mexico. And, Ray will enjoy this. This is, where I kind of saw some ER stuff where like a guy came in one time and had was fishing for bluefish and had taken one of these hooks and managed to stick it in the side of his arm. And so I had to take the bluefish hook out of his arm. If any of you guys ever fish for bluefish, it's a huge hook, and it's a stainless steel hook, and it does not cut very easily. Actually broke a couple of pairs of pliers before I found something that would cut that hook. But anyways, so, you do get to see some interesting things that way.
So Dan, when I was in private practice back in Georgia, I built my own urgent care center. And, in urgent care, you're always pulling things out of people. I kept everything I ever took out of anybody. I would put it into a little red tube and put it in a rack and hang on to it. And the weirdest thing I ever saw was a fish hook that still had the worm on it. I saved it.
I didn't have one of those. I did not have one of those. But I literally did. I had to get one of the maintenance guys with a pair of bolt cutters to actually cut that hook out of that guy.
Yep, ingenuity. That's what it takes. Keep going.
Yeah. So on a fly day, this got a little messed up. But anyways, on a fly day, so you did get depending on your airframe, you would get to fly maybe once a week or maybe once a month, depending on, you had to log 4 hours. And certain airframes only didn't fly for 4 hours at a time. So you might have to go fly once a week in order to log your 4 hours a month. Other airframes, cargo and air refuelers will they'll do an 8-hour sortie. So you'll get all your hours in one flight a month, one sortie a month. But anyways, it would look something like this. You'd get up in the morning, you'd go do your PT kind of like you normally would do, but then you go to the squadron for the kind of pre-brief activities. You'd have to go kind of check off all your equipment and make sure it was good to go, sign off any training activities that still need to be done. And then you get to the briefing room. Everybody would do what they call a time hack, in which case you'd kind of coordinate all your watches to make sure everybody's watch is on the same thing, because a lot of missions required coordinated timing. Then you'd have the mission brief, whatever was happening that day in terms of, is this just a dogfighting kind of training thing, or are we going to go out and practice delivering protecting a bomber or something like that, that sort of thing. Then you do a weather check, see how that's going. And after that, you go to life support, get on your flight gear, come back to the ops desk and get a briefing about what's going on around the airfield that day. Anything you need to be aware of as far as airfield operations. Oops. And then you go to the jet, meet your crew chief, do the walk around check, make sure there's nothing hanging off the jet that shouldn't be hanging off the jet, making sure that things are the configuration of the jet looks appropriate to what you expected. If it was supposed to have external fuel tanks, it had them, and so forth and so on. Then you'd hop in, do your engine start, do your pre-flight check, and call ground control, taxi to the runway, take off, and do what you got to do. For a fighter mission, it was usually about, it depended on what we were doing. Sometimes it was less than an hour, but the longest one was probably about like a 1.5, so like an hour and a half. And then after that, come back to land, do your post-flight checks, take all your gear off, and then go ahead to debrief. So that was kind of a fun day. And here's what happens on a bad day when you're a flight surgeon. So you might get up in the morning, go to your PT, you might start clinic. And then, unfortunately, you might get notified of an in-flight emergency. The flight surgeons had primary responsibility for the medical response to any kind of in-flight emergencies around the flight line. So if that happened, pretty much everything got interrupted. So pretty much you cancel the rest of clinic, you gather up the EMTs. So all of the technicians in your clinic, in the flight surgeon clinic, are all EMT basic certified, and there's usually one or two that's EMT paramedic qualified. So you gather everybody up, you go jump into the ambulance, and you drive to the flight line, and you wait around, or you meet the air crew wherever they happen to be, basically. So there was times before where I actually had to jump into a helicopter and they were going to pick the guy up out of the Gulf of Mexico in a helicopter. So I jumped in the helicopter, and when they reeled him up out of the water, I mean, I was on the helicopter kind of taking an assessment of the pilot at that moment. So, and then the important thing for you is you just start gathering information, because there's going to be a investigation about what happened, especially if a jet gets damaged in some way, or if there's loss of life. And that whole process can pretty much take the rest of the day. You can pretty much, if this happens to you, you can call your family, your wife, or whatever, and go, I don't know when I'm going to get home tonight. It might be really late. It probably will be really late. So,
Dan, what's the worst injury you saw?
Thankfully, during my stint, I didn't see anything more serious than just like a little case of hypothermia from being dunked in the Gulf of Mexico on a cold day. And I'm happy about that. But I clearly, as a flight surgeon, I've heard of a lot worse. When you have a jet that's flying 400 knots and it runs into something, it's usually messy. There have been issues during air shows as well. Air shows are really dangerous, where people, pilots that were invited in to perform for the air show had issues, and that there's been times where pilots have actually crashed into air show crowds before, so that's just bad. All of a sudden, you're in a mass casualty situation there. All right, so here's kind of a case example of a patient that you might see as a flight surgeon. You got this 30-year-old F-22 pilot. He comes to your clinic on Monday morning, and he goes, he's got no medical problems. He's obviously very healthy. He goes, "Hey doc, over the weekend I was just pushing it up, and I was drinking, and I got caught by the police, failed a breathalyzer test, gets a DUI. All this stuff gets reported to the base leadership." You start talking to him, and here's his alcohol consumption. He drinks 3 or 4 drinks 2 to 3 times a day during the work week, and then on the the weekends, he has 5 or 6 drinks a night. And I got the definition for the NIH definition of heavy alcohol use over there for you. And so he clearly meets that definition. So here's the question: what do you do as a flight surgeon? So this guy's a skilled pilot. He's a Top Gun graduate. It means there is a lot of money invested in his training. He's also well respected in the squadron and around the base. Do you ground this guy? If not, why not? Is he going to be a risk for some sort of in-flight incident? And if the investigation finds out he's been drinking excessively prior to getting in the jet, and maybe you knew about that, how's that going to look? if you do ground him, how's that going to go over with the base and the squadron leadership and the other guys? It's not a comfortable position to be in.
And yeah, what happens if you don't ground him and something happens?
Well, yeah. So if you don't ground him and something happens, then they're definitely going to come back at you. It's going to come back. Absolutely. But it's tricky how you do these things. So there's
and then there's the old phrase that people lie. Whatever they admit to, it's times 3.
Yeah, absolutely.
And so this guy probably drinks a lot. And the question is why? You know, he knows that it's risky behavior, but he's addicted to alcohol. And can you help him move on?
Yeah. You know, I don't know. I mean, this is obviously, it's been 20 years since I've been in, well, not quite, but 15 years or so since I've been in the military. But I don't know if the culture has changed much. It probably hasn't. But you know, back then there was definitely this sort of bravado about fighter pilots. Womanizer, drink a lot of alcohol, that sort of thing. Kind of what you saw in the movie Top Gun. That was still there. And there's a culture that influences guys to act like this, basically.
The thing is, if you don't deal with it, terrible things happen. For example, in Georgia a couple of weeks ago, there was a case of an ambulance where the medic driving had an open bottle and was intoxicated, crashed the ambulance, killed the patient. And obviously the medic was busted, charged with vehicular homicide. But could that somehow have been anticipated and headed off?
Yeah.
So Dan, you're on the admissions committee. We get applicants all the time who are having to explain on the application, okay, I was caught, I was put on notice because a beer can was found in my dormitory room, which is not allowed on campus. And I don't have a drinking problem myself. And I attended the sessions that they had me attend. And I promise that this won't happen in the future. So often in these sessions, we've said to the students that are listening, for goodness sake, you're working so hard for your career in medicine, whatever it is, NP, PA, doctor, don't put yourself in an odd situation for God's sake of getting a DUI. If booze is not allowed, recently I saw an applicant or a while back, I saw an applicant that was caught with marijuana on a campus where marijuana is not even legal in that state. You just don't want to have stuff on your application that you have to explain. Would you agree with that?
Yeah, absolutely. Absolutely. And even if it seems something minor, like, it was a can of beer, it wasn't yours, but it was in the dorm room or whatever, you still need to, what's the right word? You got to accept responsibility and not sound like you're, kind of blowing it off like it, like you had nothing to do with it. You still got to accept responsibility and demonstrate that you understand the gravitas and the importance of what that possibly might have meant for your career, or still might mean for your career, and what you've learned from that and how you're going to change. I think that's the most important thing.
I actually read the monthly bulletin that comes out from the Texas Medical Board of the several dozen physicians each month that have been busted for DUIs, for self-prescribing, for prescribing narcotics for close family members and things like that. And would you say it's a fair thing that we're trying on the admissions committee to try to weed out people that seem to indicate that they have a problem on the front end?
Absolutely. Because it's a lot harder to do it on the back end.
Well, please keep going. So what'd you do with this guy?
So, it involved a lot of talking with a lot of people. So I did have to ground him for a little while. But we worked through it and found a way to, get him seen by psychiatry, and then get some get him into a treatment program. And then while he was in the treatment program, we had to drug test him frequently. And as long as he passed his drug test, then we would let him go fly. But, it's difficult and requires a lot of coordination from a lot of people. So it wasn't like Dr. Septum at that time, the lowly 03 captain at the flight surgeon, made the decision on how to handle this. This definitely went up the chain of command to all the medical chain of command, as well as the base chain of command, to figure out how to handle this appropriately. So, yeah.
That's great. Keep moving.
Yeah. Well, I think we're actually back to the point where I'm going to take a break at the moment. Or take questions, I should say.
Well, the first question is, are there AA groups on bases? If not, what resources would you give them?
That is an excellent question. I have not known of an AA group that meets on base, although it's possible. When you are in the continental United States, of course, there are AA groups just about everywhere. So as long as the base is somewhere in the US, it wouldn't be hard to get to an AA group off base. If you are overseas, it would probably at that point fall back onto the local behavioral health specialists on your base to kind of help handle that situation.
Thank you, Dan. Cheyenne, do you have about a dozen questions already for Dr. Septum?
Yes. Ooh, and thank you so much, Dr. Septum, for sharing your experiences with us. We do have a couple of good questions here. So one of the first questions that the students have asked, what did the military teach you that a traditional path could not?
Interesting question. I think, as I said, the military exposed me to some experiences I don't think I would have had in a traditional sense, and that made me very comfortable with some things. Like, for instance, when I was deployed once to Ramstein Air Force Base, and what we did at Ramstein is we met the inbound flights from Iraq and Afghanistan that was full of wounded soldiers. And it was our job then to transport these guys from the flight line to Landstuhl Regional Medical Center, which was about maybe 8-10 miles away up the road. And, some of these casualties that came off the planes were really busted up. Okay. They had, been hit by IEDs, and someone had their legs blown off, and, it's pretty traumatic kind of stuff. Each of the critical patients would come with their own CCAT team, which is a critical care air transportation team. And we would kind of help out with that stuff. And it was our job to then take these seriously injured patients and transport them to Landstuhl. And I got comfortable with like pushing morphine like you wouldn't believe. Like nowadays, like if you're in one of our ERs or something like that, you're going to give someone a little morphine, you give them like 1 milligram, 2 milligrams or something like that. Some of these like Marines that came up from downrange that were totally busted up, I had no problem just dropping 10 milligrams of morphine in that guy, because I knew he was going to hurt on this bumpy bus ride all the way up to Landstuhl. And you just got comfortable with certain things like that. Because you were responsible for doing in-flight emergency response, you kind of got comfortable just kind of handling the, like, okay, I have no idea what's going to happen next, but okay, I'm here. The pilot that got dunked in the Gulf of Mexico, I had no idea what was going to be like when they pulled him up out of the water. But you just kind of get comfortable with kind of dealing with the little bit of uncertainty there.
That's right.
So I think that's probably the main thing. I got comfortable with dealing with things I'll never experience elsewhere and sort of uncertainty.
And we just got a question from Ashley. That's a good question. There are a lot of benefits from being a military doc, but did it come with less freedom for you choosing your path? I think you're going to touch on that in the second half, aren't you?
Yeah, I mean, that's great. I might as well touch on it now. It's no big deal. Yeah. So if you're so it depends on what you mean by freedom. If you're talking about freedom in terms of specialty choice, there is some restriction there. So if you've already decided that you have to be a whatever and pick the specialty, if that specialty happens to not be something that is required by the military, then they're probably not going to let you do it. That doesn't mean that you can't ever get back to it. You can. There's ways around it, but yeah, it could be a little restricting at the start. So, but if you're going to do something that the military needs a lot, so if you're going to do primary care of any sort, general internal medicine, family medicine, general peds, excuse me, you're going to do emergency medicine, general surgery, that's no problem. I don't think you have any problem getting approved to do a residency in any of those kinds of things, because the military just needs those, a lot of them. But let's say you wanted to do let's say you had to be a pediatric cardiothoracic surgeon, okay, which is like ultra specialized. Well, that's just not something the military needs a whole lot of. So you might not be approved to do something like that right off the bat. Now, like I said, there are ways around this. So I knew guys that ultimately wanted to do some other specialty that the military probably wasn't going to approve them for at the time. And so what they did for a short time is they just did an internship, a transitional internship, 1 year, and they went in the military and they served as what's called a GMO, or a general medical officer. Sometimes as GMOs, they served as primary care physicians, and sometimes they worked as flight surgeons and took care of patients. And then when their payback time was up, they reapplied to the match to whatever specialty they wanted to do in the civilian world. So that, it did kind of delay things a little bit, but at the same time, once again, financially, it ended up being probably a good thing for them. And I think most of them got ultimately what they wanted to do. I think one of my GMO flight surgeons, when he got out, he ended up being a pediatric immunologist. So that was kind of cool.
Dan, I talk to the residents all the time, obviously in our emergency medicine residency program. And it almost seemed like the average debt that they have is between $200,000 and $300,000. It sounds like you escaped a lot of, if not all of your debt, by enlisting in the military. Is that true? Or
yeah, so I was lucky. I went through George Mason on a full scholarship, so that was kind of cool. And then it's not unlike I know, like some of you guys went to UTD. The UTD has a similar type of thing. If you qualify for some of their scholarships, it's a similar thing. But anyway, so I got out of undergraduate with no debt, and then I went did the Air Force thing, and so yeah, literally undergraduate med school, zero debt. So even though the first year as an intern, my salary was $28,000. At least it was a positive $28,000, and there's no student loans to pay back.
So any advice, any grandfatherly or fatherly advice to the 166 people listening tonight, as far as should they think twice about taking down a whole wad of debt? Does it ultimately pay back? Is it worth the investment?
I think
that's a tough question.
That's a tough question. I think you do have to be careful about debt. And I think the amount of debt that you carry does influence your subsequent decisions about what you decide to do in life, right? Like if you are significantly, if you're $300,000 in the hole, you're going to think real hard about doing some sort of specialty like family medicine or primary care, where the monetary remuneration is not as big as something else, because you're thinking to yourself, like, I'm going to be in debt for the rest of my life. The truth of the matter is, you can actually pay back those debts, in primary care. People do it all the time. It takes some discipline. It means that, you can't get straight out of residency and buy a Ferrari. But, you can pay off those student loans, even in primary care specialties.
And there are other ways. Yeah, and there are other ways to pay off student loans. For example, going and practicing in a more rural environment where their loans may be covered. Certain practices may help you with your debt if they bring you on as an employee or as a contractor. So there are other ways to do that. Let's take a couple more. This is great stuff. Cheyenne, you have two or three more questions for Dr.
Sure. Yes. So one of the other questions that the students were wondering, what other qualities would you recommend an individual to have who wants to pursue a military program? I know that earlier it sounds like you mentioned that being non-attached is important. So do you have any other characteristics that you'd recommend?
Well, so you have to be able to take orders. I mean, if you're a really independent person and you like being told what to do, sometimes the military is not right for you, because there are times when you're going to be told to do something and you're not necessarily thinking it's the greatest thing to do, but you're going to have to do it. I mean, case in point now with the whole COVID-19 vaccine, right? That's coming out. You know, in the military, we were required to get all sorts of vaccines because we had to be deployable to whatever country, whenever. And I don't remember back, 15 years ago, anybody, freaking out about having to get their smallpox vaccine or anything like that. But oh my gosh, just because the COVID-19 is very political now, it's like, no, military members should have a decision about a choice about whether or not to get the COVID-19. In my opinion, no, you don't. If the military says you get it, you get it. You signed on the dotted line. You don't belong to you anymore. You belong to military. So there's a case and example of, where you might want to think about it if you're not the kind of person that's okay with that. But I mean, other things that, if you got to have good people skills in the military, because you're going to interact with all sorts of different people, and you got to know, the chain of command and who's buttering your bread on which side. Take my point of view there, and to kind of understand how to work the system.
So Dan, I have a question for you, and it's back to the admissions committee for a moment. I was reading this week, and it said down from 44% that in the past year, about 41% of all applicants to medical school get in, which means that's pretty good. That's close to half. And so medical school applicants have never been higher during this COVID era. I think part of it, Dan, you probably agree, is because we can interview virtually and you don't have to travel around the country, that you can interview virtually in many, many places. But with as many as 1 in 5 medical people dropping out because of burnout and just saying, I don't want to do this anymore, and yet on the other end, so many people are applying. Is there some kind of message to give to folks who are listening tonight about, there are a lot of people on the back end that decide that they don't like this job? Do you have any thoughts about that?
Yeah, so I have two thoughts. The first one is, a job's a job. Like, even medicine, a job's a job. At the end of the day, when you have to bow out of medicine for whatever reason, maybe it's age or some other, maybe you develop your own medical condition, you can't continue practicing safely. The people that you work with, they might come visit you once or twice, but honestly, they're not going to come see you that often. Yeah, what you're going to have left is family. So, I mean, if you want to combat burnout, I think one of the most important things to do is take care of your family first. Okay, take care of your family first, and they'll be there for you, and they'll support you in the tough times when your job sucks and it doesn't feel like it's what you want to do. So take care of your family. That's number one. Number two, I really would not pick a specialty simply because of the prestige it brings or the amount of money that it might make you. There's plenty of research studies out there that'll show you that people that make tons of money are not any happier than people that make significantly less. I think I forget which study. There's some study out there that says somewhere if you make somewhere between 175 and 200 or so $1,000 a year in current funds, you're probably comfortable enough to be as happy as anybody that makes $1 million or $2 million a year. I can't remember exactly what the data said, but something along those lines. So pick something that is going to make you wake up in the morning and feel like, yeah, I want to go to work because I like what I do. I genuinely like what I do. Like it, that would be my other bit of advice, whatever that happens to be.
Dan, do you like what you're doing as a family medicine doc at a university? I know you're about to get into that, but is that where your heart of hearts is, aside from your family?
So I like being a family doc, but you know what I like, even I discovered, even when I was going to say this, when I transitioned back to Southwestern, what I found I liked even more actually was teaching. Um, so I do like being a family doc, and there's a lot of benefits to it, which we'll go through later. But I really was surprised at how much I liked and loved teaching, and so I like seeing you guys come up through the ranks and become students, and eventually become residents, and eventually become my colleagues. I've had several students now that have come done just that, and they're out now practicing family medicine in the local area, and they're my colleagues, and I'm proud to call them that. And thankfully, most of them are way smarter than I am. So there you go.
Yeah, I feel the same way, Dan. For so many reasons. I went from the private sector to 21 years ago to an academic career, and I've never looked back for all those reasons. But I have to honestly say that I've been very lucky. I'm doing something that is the best thing that I do with my life. I love being a doctor. It's a lot of work. I read and study all the time. And, I was in Parkland ER last night, and we got our butts handed to us. We were so busy on a Monday night in Parkland. Crazy, smoking busy.
You knew that was going to happen after Thanksgiving, though.
Oh, of course, and of course, family medicine patients kept us pretty darn busy. Thank you very much. But I honestly say that, for the folks listening tonight, that it really is possible to really love what you do. So please don't be skeptical from when we say be cautious. That what Dan said is so golden, is that you want to be in something that you enjoy getting out of bed in the morning and doing it. And as I'm preparing to take my shower, get cleaned up, I say, I get to go and do the best thing that I do with my life. And, that's a pretty good thing to do in the morning, don't you think?
Some of you guys may be getting pressure from family to go into medicine. As a Asian guy, I certainly got pressure from my folks to go into medicine. And I'd always had this military bent. And so that's how I ended up kind of going in the military, because I said, fine, if I'm going to do medicine, I'll do it, but I'm going to do it my way. And so that's how I ended up in military medicine. You might, some of you, like, if you really hate it, don't do it because your parents are pushing you. You might have to just disappoint them. And it's better to disappoint them now than after you've invested tons of time, energy, and money into the endeavor. Anyways.
So you made a transition back to civilian life. Tell us about that, Dan.
Yeah, so that was an interesting thing. I knew I was so yeah, let me just say very briefly, like, the military was good in a lot of ways. Got to travel a lot, got to see a lot of things, do a lot of different things. But it had its downsides. You saw the photo there with my wife and 2 kids. And it was really tough on the family. I think the military was rougher on my wife and kids than it was on me. When we got sent to England, we were there for about maybe 2-3 months. Before then, I got deployed to Germany to help with that whole thing at Ramstein. And so I left her in the UK, in a country that, they speak English, technically, if you can understand them. Sorry about that, anybody in the UK. But they do things just differently, right? It's just different. So I left her in a foreign country with 2 little small kids and said, see you later. I'll be back in a few months. That just didn't go over real well. So anyways, the reason I got out was really for my family. And I wanted to, in the military, you're also going to move at a minimum at least once every 3 years. And the higher you go up in the rank, actually, the more you get shifted around. So by the time you make lieutenant colonel, you're probably moving once every 2 years to a new base or something like that. I just didn't want to drag my family through that. And so, and there was always a constant threat of getting deployed. And so that's the reason we got out ultimately.
By the way, Dan, did you have to do flight training? I meant to ask you that.
Yeah. Yeah. I mean, it's not the same. It's very rudimentary. It's not the same as what a pilot gets, right? Like, am I a pilot? No, I'm not a pilot. I cannot fly a jet. In terms of safely, like, can I, like in a pinch, could I, maybe keep it from crashing? Yeah, probably. But that's about it. I know that when you push the joystick forward, things get bigger. When you pull it back, things get smaller. You go this way, it rolls this way and that way, right? Just some basic stuff right there. People who probably do the, what's that, the sim flying thing on Microsoft, they're probably better pilots than I am.
All right, keep rolling.
So, I just wanted to emphasize that connections are really important in life. And this certainly is how it panned out for me, getting back into the civilian life. As I was trying to get a job, I happened to get in contact with one of my previous faculty members at UT San Antonio, who was actually writing a book on how to write physician CVs. And he says to me, "Hey, Dan, if you let me write your CV for you and use it in my book, I'll do it for free." And I was like, "Let me think about this. You're going to write my CV for me? You got it. No problem. You can stick it in your book." So he wrote my CV, and that same faculty member also got wind of another faculty member who was slated to become department chair of family medicine here at Southwestern. So I sent her my my resume, and she said, "Hey, yeah, I remember Dan. Yeah, let's have you come in for an interview." So I flew in for an interview. One thing leads to another, and there you go. The first job that she had me do was working with what we call our pre-doc division, which is basically the medical students, and helping to run the third-year clerkship. And I thought to myself, yeah, I haven't taught anybody anything in 6 years. This is going to be really interesting. But it amazingly went well, and I just loved it and just kept going from there. So can't remember, is there anything else? Yeah, there we go. When I first got back, she did have me I was assigned to a clinic where I was treating patients. I was probably in clinic about four days a week or something like that, and the rest of the time I was slated to do some sort of teaching stuff. Since then, my job is totally expanded. I do pretty much everything now. I am involved in teaching at all levels, from the pipeline level up to MS1 students, 2s and 3s and 4s, and then residents, and then even faculty development now. So I kind of do a little bit of everything.
So Dan, are you a better doctor because you are communicating what you do to learners all the time?
I think I am. And I think I stay more up to date because people are always, I'll say something and they'll be like, "Hey, they changed that last week." I was like, "What? Tell me about that." The organizations that make these sort of guidelines for how to treat various different things, the guidelines are always changing. They're
always
the same.
I'll give you an example. American Heart recently changed, actually, the American College of Cardiology recently changed what's called the classification of elevated troponin levels. For the students, that means the enzymes inside heart muscle that leak out into the bloodstream. And they changed it, the type 1, type 2, type 3, to a new type 1, type 2, type 3. Type 1 being actual heart damage due to a clogged up artery of either thrombosis or plaque. Type 2 being every other cardiac cause of leaking the troponin enzyme, and type 3 being everything else like renal failure. Well, I bring that up because we have to continue to study and learn that stuff. And it starts really from the professor level down, because we have to learn that stuff all the time. I was saying the other day that if I come to the bedside of a patient and I don't know something, which I need to point out is common, I either never knew it and there's a lot of that, or I forgot it. And wait till I'm 69 now, wait till you hit close to 70 now. It's easy to forget. Or it's brand new stuff. They've changed something, or new stuff has been discovered, such as things in the immune system. So man, it is a constant struggle to continue to read and study and keep up and remember.
Yeah, absolutely. And I'm just thankful for all the online resources these days that you can just tap into fairly quickly, and kind of look up answers to information, because you just can't know it all. And it is always all changing. So, yeah.
Keep going.
Yeah. All right. So I'm going to change gears just a little bit and just talk a little bit about family medicine. And as we go through this, I'll tell you what kind of attracted me to family medicine and why I do family medicine. So just want to take you back a little bit and do a little history lesson. So, in the beginning, medicine in America was fairly rudimentary. Okay. So this is a guy, Ernest Sirianni, just shortly after World War II. I think it's like 1948, 1947, something like that. Most doctors went to med school and they did an internship. That was it. 1 year of some sort of postgraduate training. It would be equivalent to what we kind of now would consider a transitional internship. And then they went back to whatever hometown they were from, and they opened up their office, as it were, or as we used to call it, put up a shingle to indicate they were in business. And they went about treating the patients of the town where they lived and worked. And you see this guy carrying his black bag. This was a time of what we call high touch but low tech. So, in terms of technology, you see you got the roll of toilet paper there, and the thermometer, and that was pretty much it. If this doctor wanted labs, or an X-ray, just a simple X-ray, he might have to send the patient to the local hospital, which, let's say it's close, maybe it's 10 miles away. Well, this happens to be rural Montana in 1948, so the roads aren't very good. So even to get to a hospital 10 miles away in 1948 might be quite a chore and a task to do. So it's difficult. But this doctor knew his patients really well, because he saw them every day, like when he went to the grocery store, or when he went to the filling station to get gas. And obviously you can see he's doing house calls here, because that's how it was done back then. The patients didn't come visit you in a nice shiny clinic. You went to see them. And the people in the neighborhood, in the town, always knew who was sick, because they knew what sort of car the doctor drove, or even before that, they knew what sort of, kind of horse-drawn buggy or carriage the doctor was in, and they knew where it would have been parked. So this was definitely from a technological standpoint, a simpler time, but a time where there was a significant more relationship with the patients. Everybody knew this doc, and they would do things for him, right? Like if they couldn't pay him for his services in money, they might pay him in goods or services, like bring over a casserole or bring over a chicken. They might paint his house for him or fix his car for him for free, that sort of stuff. That's the way it was done. So what happens next? Well, we all got a little bit more advanced technologically speaking for various reasons. There were industrial revolutions. There's wars that spurred on technology, and then space race and things like that. So we have the rise of the specialist. Anybody have any thoughts on when residencies came into play, by the way? Just going to throw that out there. So I can't see the chat, so maybe someone's got the answer. But somewhere around 1971, the very first residencies started to pop up. And residencies popped up because people were specializing in somebody would say, "Yay, verily, I'm an ENT, or I am an OBGYN, or I'm an orthopedics guy," and before this time, there was no specialized training that you got. You just decided that's what you wanted your practice to be. You just wanted to do ear, nose, and throat stuff. Well, the public wanted some reassurance that if you said you were an ear, nose, and throat specialist, that you actually had some extra training in ear, nose, and throat. And so residency started to come about. And in fact, I believe otolaryngology, ear, nose, and throat probably was one of the very first specialties out there. I think family medicine, or did I get the number years wrong? I think so. Yeah, so maybe ENT was earlier, like 1950 something, because I know family medicine came along as a specialty in 1971, I believe. Anyways, so you can see the stats there. Is the interest in primary care declines, the number of people that are applying to family medicine and primary care specialties. And I define primary care specialties as general internal medicine, general pediatrics, and family medicine starts to decline.
I know emergency medicine became a specialty in 1979, and the first boards were given in 1980.
Excellent. So, I mean, that's, yeah, because I knew that ER was a little bit younger than family medicine, but not that much. So, I think family medicine was a little late to the residency game because, like, by default, if you didn't do a residency, you kind of were a family doc for a while there. So I think they were like, oh, why should we have a residency when, anyways. But,
so is family medicine considered primary care?
Yes, absolutely. Yeah. And you can look there as far as, physician shortage, manpower reports there. This is a recent AAMC report from June of this year. If you go into primary care, you're going to have a job. Don't worry, because there's going to be a shortage. And like you can see there, it depends on how accurate the report is, but somewhere between, close to 18,000 to 48,000 physicians short by 2034. And, sometimes I get questions about like, well, are you afraid that, your job is going to be usurped or taken up by, nurse practitioners or PAs or anything like that? And my answer is absolutely not. And the reason is because there's just so many, like, you guys know the baby boomer population has now gotten to Ray's age. I'm sorry, Ray.
Careful there.
And they're getting all sorts of conditions, and they all need primary care docs. And so, and there's just more than enough patients to go around, basically. I am not afraid of mid-levels, as they're called, kind of taking over or anything like that. And also, there's just, innumerable times where you'll talk to patients and they really want to see a doctor. I mean, it's okay for them, they accept seeing a mid-level from time to time, but at the end of the day, they feel more comfortable when they're seen by somebody that has the MD or the DO behind their name, so I'm not concerned about that at all. So, what is family medicine today? So we still strive to provide comprehensive primary health care. So that doesn't mean we're the definitive answer for everything, but we're a good place to start. We provide care to individuals and to families. We provide care to all genders, all ages, all diagnoses, even complicated ones. Like I said, we might not be the definitive answer or treatment, but we definitely help out. I have patients that are patients of mine that are very complicated. And no, I don't necessarily directly help them with things, for instance, that might require surgical intervention, but I do help them through the process. I get them ready for surgery. I receive them on the back end after the surgery is done, and I help to manage their medications and side effects and different changes that might have occurred because of whatever surgery they had or whatever treatment the specialist has been doing to them. So I still have some very complicated patients. I have a patient that just right off the top of my head I can think of, a patient that is relatively young, in her 30s, that has had a heart transplant. She's very complicated. I got another guy who also very young and had a condition which caused him to have what's called situs inversus, which basically means all his major organs are sitting on the wrong side. So his heart's on his right side, These are complicated patients, and yet I'm involved in their care. And when they need to see a specialist, I make sure they get to see the specialist and help to kind of quarterback that. And one of the things I like about family medicine is I don't have to say, no, I don't do that. Like I'm not trying to rag on anybody, but, for instance, if you're a OBGYN, like you just don't do guy stuff. Like that's just the fact, right? So what kinds of things do we do? We take care of acute illnesses, injuries, coughs, colds, sprains, strains, fish hooks, all that kind of crazy stuff. We do see patients both in the clinic setting and in the hospital setting. There are some family docs who choose to do nothing but hospitalist medicine, and they just see patients in the hospital just like an internal medicine hospitalist would. In our residency, we run 2 inpatient services, one at Presbyterian Hospital in Dallas and the other one at Parkland. And the patients that you're going to see on our service are no different, no less complicated than the ones you see on the internal medicine services. We spend an inordinate amount of time talking to our patients about preventive care and health promotion. I am a firm believer in trying to keep people from getting sick, and I talk to them all the time about exercising, eating right, getting their appropriate vaccinations, and appropriate screening studies like mammographies, colonoscopies, pap smears, and things like that. I certainly do take care of chronic diseases. I take care of things like diabetes and hypertension and hyperlipidemia. Absolutely. There are some, I don't do this, but there are some family medicine docs that do maternity care and deliver babies. One of our docs in our residency program has OB privileges at Presbyterian Hospital and delivers babies there. And we have another one that's working at Parkland in the OB division there, delivering babies as well. I don't even think some of the OB residents realize he's not an obstetrician, but he's a family doc.
Dan, what do you do when you have folks that you're advising to get vaccinated, various vaccines, and they won't do it? Do you fire them? Do you talk to them? Do you counsel them? What do you do?
Oh man, we've had long discussions about this, Ray. So the university won't let us fire them. So that option is off the table. I'm going to talk in a minute about, kind of some of the important characteristics of being a family doc. And one of those is being a partner with a patient over an extended period of time. And I think one of the best things you can do to try and convince someone is to just become a friend to them, a trusted friend, right? Like you're going to trust advice from a trusted friend. And so you can't strong arm people into doing things. But if you can convince them to do something, then that's better. And it just takes time and energy to keep talking to them about the same thing over and over again. Keep hitting on it, I think.
Manur has just asked us a nice question. As a family doc, do you find that you are pressed for time to have enough time with each patient? Get one in and out in every 13.8 minutes or whatever?
Yeah. So that can be that can certainly be an issue. First of all, let me just say that there are different models of outpatient primary care nowadays that kind of address that issue. Like, I don't know if anybody's heard of direct primary care, but in direct primary care, you offer your services to a group of patients almost like a gym or a health club membership. So patients will pay whatever amount per month that you think is reasonable for a certain level of service. And basically, let's say, I'm just gonna make numbers up, but let's say a patient can join your practice for $50 a month, and they pay you $50 a month, regardless of whether they come see you one time or 3 times or 4 times. If you get enough people in this pool, it basically allows you to make a reasonable, actually not just a reasonable, a very good living, and manage the number of patients that you have to see every day. because some patients are not going to come in at all, just like at the gym, right? Some people buy a gym membership and never come in, and other people are going to come in 3 times, and that helps to kind of even things out. Even if you're not in a direct primary care payment model, there are ways to sort of help massage your schedule on a daily basis to kind of make sure that you try and spend the appropriate amount of time with every patient. Let's put it that way. Some patients, are going to take a long time, and you may spend longer with them. And because you do that, there might be some other patients that come in for a very quick, simple thing, and you're going to spend less time with them because there is a finite number of hours in the day, and you have to sort of manage that schedule to kind of make it all fit, sort of like a little jigsaw puzzle.
You have patients you see now that you've been seeing ever since you've been at Southwestern? I mean, you have a long-term connection with them?
Yes, I do. And I'm laughing because some of their stories. I mean, I would share them with you, but I would probably get in trouble from a HIPAA standpoint. I just know them too well, and if I tell you the story, you could probably look this person up, But I know the stories like on the back of my hand exactly, what their problems are and what they're dealing with right now, and they're I know their history, where they came from, what they did for a living, who they were married to, I've met their kids and their grandkids, and yeah.
I do have a question, and I'm sorry to keep butting in, Dan, but God, you're bringing such important things up. Some patients come in, and really what they need is reassurance. You check them over, and nothing seems to have changed. They're doing what you asked them to do, but there's something on their mind. And you find that what you're really doing is reassuring them. Is simply reassuring the practice of medicine?
Oh, I think it absolutely is. One of the things that so when you start off as a younger, or at least I don't know about Ray, but me as a younger doctor, one of the things when I started off was I was all about like always trying to like fix things, right? Like I had to like fix something. I had to prescribe a medicine. I had to do something. And after a few years, I started to learn there was some subset of patients that really didn't need me to fix things. They just needed me to listen. Or they needed me to just reassure them, like Ray was talking about. And sometimes if you did things, like if you prescribed medicines or you checked labs or something like that, you could actually make the situation worse, because sometimes the patient really is healthy and they're doing fine. And the best thing you can do is to just listen and reassure them and do nothing else.
Do you find that you're wiser now that you've been out for a few years, the chest pain, the abdominal pain, based upon the workup that you've done and your experience, that you trust your own opinion more than you did when you were a younger man?
Yeah, no, I think that's right. It kind of goes to what I was saying a minute ago. When you're younger, I think you have a tendency to kind of over test and over order things and maybe a little bit over prescribe. But once you've seen, been out a few years, 4 or 5 years, seen several thousand patients at that point, you sort of you really get a really good idea for what is sick and what is not sick, and I think in the ER, of course, that's really critical, right? You're trying to figure out who's sick and who's not sick. So I think you get a really good feel for that after a few years.
How do you handle getting sideways with other docs? For example, recently I had a hemodialysis patient, and for the students, the hemodialysis is a patient whose kidneys have failed, and they're on a machine 3 days a week to filter their blood. It's a tough existence for the patients. And this guy came in with melanoma, which is, as Dan well knows, is blood in the gut. And the patient was on aspirin for cardiac stuff. Complicated patient, as you know. And I found myself getting sideways with the referral doc, because how in the Lord's name do I manage these complicated issues in the ER when I have so little time in the ER? Do you get sideways with other docs, referral docs sometimes?
Yeah, well, as I mentioned to you, because we're we're primary care. We're not the definitive answer for everything. So we have to rely on consultants and the help of specialists sometimes. And yeah, sometimes that can get contentious. I had a patient middle of the summer who came in for some vaginal bleeding from a uterine cancer. And, so and the bleeding was heavy and she wasn't stopping. We had to give her a unit of blood and whatnot. And I thought, well, we should consult gynecological oncology because that's what they do, right? So I consult gynonc, and I get the guy on the other end, and he reviewed the case, in the computer, and then he calls back and he goes, well, what do you want me to do? And I'm like, what do you mean? What do you want me to do? Like, shouldn't you know what to do? And he's like, well, there's nothing to do here. And that was it. And I was like, okay, so you just want me to keep pumping her with blood? Like what, it was not the most helpful consult in the world. And he was actually quite belligerent about it. Like I was bothering him. So, sometimes that sort of stuff happens. So how did I deal with that situation? Thankfully I have friends. So I called other people and I found people who were helpful. And so that's how I kind of dealt with that.
I had a similar one, a woman who was bleeding very badly vaginally and was getting a blood transfusion and started shaking, and was observed by the staff that this patient was having a seizure. And what I strongly felt was that it was a shaking chill associated with a transfusion reaction. That's what I thought. And so I found myself getting sideways with the endocrine OB-GYN oncology staff saying, folks, I don't think this patient's having a seizure. That's my assessment. And so just being an example of how you can get sideways. And what I was telling Kevin, who asked me about that, you just have to be honest about what you do know and then always advocate for the patient. Would you agree with that?
Yeah. I mean, yeah. That's the main, the really thing that got me about that situation too was, the surgical, the gynecological oncologist, like, at the end of the day, he just didn't help this patient out at all. And I was like, you can't just leave her like this. You got to be kidding me. You cannot leave her like this. So, if he wasn't going to do anything, I was certainly going to find someone who was going to do something.
And so, Dan, how often do you find yourself doing stuff for patients that don't seem a lot like medicine? I recently had a little old lady who kept falling out of the bed and had fallen out of the bed and got banged up pretty bad. I actually thought it had a broken arm. Turned out that the CAT scan did not show a fracture. And really there I was, this 69-year-old professor in a medical school intellectual. And what I was doing was arranging bed rails for a patient. Sometimes, the way I put it is, sometime when you can't do a lot, you do a little. Go get a sandwich for the patient,
Yeah, well, primary care, we do that sort of stuff all the time. Do I arrange home health for my patients or palliative care or hospice care? Absolutely. Yeah, absolutely do all that stuff all the time. And sometimes you have to have, difficult conversations with patients, even on the outpatient setting about, they're not getting better with whatever it is, and we're like, you need to, like, Mrs. Jones, we need to start thinking about like hospice now. And that's a tough conversation to have.
I'm on the committee in Texas. That's a thing called Texas Talks. In other states, it's called POLST. Some of the people that are online will know about this, the Physician Orders for Life-Sustaining Treatment. We do a great job of welcoming little babies in the world. We do a lousy job of people being able to control their lives as they check out of the world, as I watched both of my parents do. And, helping folks and encouraging folks to do just what you just said about hospice care, about palliative care, saying, let's ease you into an environment that's much more comfortable for you, with the understanding that this may be a target for where the next part of your life is going.
Yeah.
We had a good question from a student, Dan, about that last part that you have here on your slide, mental health care.
Sure.
How much of your time do you spend talking to folks about their anxiety, their difficulty sleeping, their insomnia, and this sort of thing?
I got to tell you, mental health care is such a big part of primary care. it's incredible. We do lots of depression, anxiety,
Alcohol,
insomnia,
booze.
all those things. Like if I decided that I wasn't going to do that anymore, and I said, "Oh, that's that a psychiatrist has to do that." If I said that, my psychiatry colleagues would absolutely kill me, because there are a lot of patients that just have what I would call garden variety depression and anxiety that we manage in the primary care setting and never go see a psychiatrist because they don't need to see a psychiatrist. There's some conditions that are a little bit more tricky, and you need a psychiatrist, right? Like if you have someone with really bad bipolar disorder, or somebody with active psychosis and schizophrenia, absolutely, yeah, I need a psychiatrist for that. But some of this other stuff, no. And I do take care of a lot of that stuff every day in clinic. And
How
sometimes it
about
doesn't.
how about dementia, Dan? Do you see a lot of that maybe increasing on the rise?
Oh yeah, I mean it's unfortunate, but I do have a fair number of patients with dementia as well. Probably when they die, we're going to find out it's Alzheimer's, but but right now it's just I'm just calling it dementia. But
I got to give
on the
you
caregivers. Sorry, go ahead.
no, I got to give you a quick aside. I don't know if you caught the news, but a couple of days ago, and I think it was at Radio City, Lady Gaga did a concert with Tony Bennett.
Yeah.
Now, almost everybody on the line won't have any idea who Tony Bennett was, but certainly in my youth and maybe in your real youth, Dan, Tony Bennett was one of the great crooning singers of the 60s, 70s. He's been around a long, long time. Well, he's 95 years old tonight, and he has Alzheimer's disease. And he got up and did a concert with Alzheimer's in front of screaming, cheering people who were so glad to hear him sing. And it was interesting that I'll shut up with this, Dan. And one of the observations was that his muscle memory about singing was intact. His memory about day-to-day stuff, buckling his belt and zipping his fly, was not intact. But he could get up there, by God, and sing "I Left My Heart" in San Francisco and woo tens of thousands of people that were rising, giving standing ovations. It's interesting.
Yeah, no, I really, I think music carries a lot. And there's something to be said for that, for sure. Music and memory. Yeah.
Yeah, well, I didn't mean to hog your slides. Keep going, please.
No. I was going to say the other thing we do, I mentioned, is a lot of sports medicine and rehabilitation. I'll talk a little bit more about that later, but we do a lot of non-surgical orthopedics, if you will. And I briefly mentioned end-of-life care. We have some docs that do hospice and palliative care as well. So all those things are available to you in family medicine. So what sorts of procedures do we do? So, sometimes I get, the comments from people that, in primary care, family medicine, all you do is you see people with coughs and colds all day long in clinic, that's all you do. It doesn't get very complicated. Well, if you want to limit your practice to coughs and colds, and that's all you want to do, can you do that? Yeah, you can. But I think that's a personal decision that you as a physician make, and you're just limiting your scope of care because you want to, not because you have to. These are all of the things that are possible, and then not even all of them. It's some of the things that are possible to do as far as procedures in family medicine. And, I do a great number of the things that are on this slide. Let's see here. I personally don't do colpos or endoscopies. I don't do tympanometries, and I don't do deliveries and C-sections, but most of the rest of that stuff I've done. So if you want to do procedures in family medicine, you certainly can. So sometimes people ask, what's the difference between a family medicine doc and a general internal medicine doc? So obviously there's no age limitation, right? So if you're a general internal medicine doc, you generally only take care of people older than the age of 18. They don't tend to do as broad a range of procedures as we do in family medicine. And, most internists or internal medicine docs are focused on inpatient medicine, whereas in family medicine, our focus tends to be on outpatient medicine. And there are some differences in fellowship options as well, which we'll talk about later. I will say that, if a family medicine doc wanted to limit their scope of practice to adults over the age of 18 and not really do that many procedures, their practice probably would look a whole lot like general internal medicine outpatient. It'd be very similar, but it doesn't have to be that way. It can, it doesn't have to be. All right. How do we compare to general pediatrics? Well, if you look at this slide, the green line at the top is the number of outpatient visits that are taken care of by general pediatricians in any given year. And then the two lines down below are the number of outpatient pediatric visits that are taken care of by family medicine in the blue and pediatric subspecialists in the red. So clearly we don't take care of as many pediatric patients as our general pediatric colleagues, but we do a fair number, about as equivalent to pediatric subspecialists. So this was a slide I was mentioning earlier about the key attributes of family medicine. I mean, this is the really important part, and I think one of the beautiful parts about family medicine is you do get to be that patient's doctor over a number of years. And as you do that, you get to understand the whole person, and they come to trust you. And you also help that patient to understand what's going on with them. Not everybody has the same level of medical understanding as you do as a physician. And so, when you can help patients understand what their labs mean, what their CT scans mean, or why they need a certain procedure or why they need a certain immunization or whatever, it puts the humanistic spin on things. And I mentioned to you, we have a command of complexity, and that complexity is not just complex medical conditions, but it's the interplay of medical conditions laid on top of social issues, right? There's plenty of situations medically that would be straightforward if the patient could just afford to get their medicines or make it to their appointments. I have plenty of patients who have musculoskeletal issues, who would probably benefit from physical therapy, but honestly, they can't afford physical therapy because every time they go into PT, there's a $30 copay. So they can only afford to go once or twice, when in fact, they would probably benefit from at least 10 visits. But the long and the short of it is, there's more complexity to caring for patients than just the straight medicine. How do you make a family doc? So our residency is typically 3 years long. There are a few that are actually 4 years long. There's more than 500 different family medicine residencies in all sorts of settings, whatever you want. So whatever floats your boat there. The family medicine residency curriculum is fairly broad in its scope. You can see at the very top of this chart here, it says continuity patient care all 3 years. What that means is, as a resident, you're assigned to a clinic, and you're going to see patients at that clinic consistently throughout your entire 3 years of residency. And so you will develop some of those relationships with those patients, as we've been talking about. You spend your other time going through a variety of different areas, because we are trying to create someone who is a generalist and comfortable taking care of all sorts of different things. And then, as Ray and I already kind of hinted at about the continued lifelong learning, you cannot stop learning in medicine. I think certainly in primary care you can't stop learning, but I think these days, regardless of specialty, I don't care what it is these days, there's just so much going on in medicine. You cannot stop learning.
I'll give you two examples. When I was the age of some of my working group, virtual shadow working group members here, I was in medical school. Pneumococcal pneumonia, streptococcus pneumonia was universally sensitive to plain penicillin. Today, of course, streptococcus pneumonia is a kind of Godzilla bacteria that you have to approach with much stronger medication. That is an example of a change as the things we treat change. Another example, excuse me, is the changing technology in the world. For example, patients now have smartwatches that have arrhythmia monitors on them. And we have a challenge to be able to say, okay, how can we hook these people into some kind of medical monitoring care to use technology to continue to improve patient outcome? That's an example of a modern day change, Dan.
Yeah, absolutely. I, for one, am very thankful for some of those tracking devices. I'm the continuous glucose monitors for the diabetic patients now that will, basically link or basically output the blood sugar level straight to their phone, and then they can send that to me in the EMR. It's just amazing. All right. Just briefly wanted to touch about the match this year. So if you look down at the very bottom of that little diagram, you can see primary care did pretty good this year in the match. We had an increase of 58% in internal medicine, 68% in family medicine, and 79% in general pediatrics. So pretty good.
And how many resident candidates applied to your program for how many spots this year? Just roughly.
Ballparking. So we routinely have about 2,000 people applying for 14 spots. Most of those, I mean, from a residency standpoint, there's no way we can do holistic review of 2,000 applicants.
No way.
Yeah, so they get cut down pretty quick in terms of, for residency spots, we're usually looking at seniors who have graduated from U.S. Medical schools within the last 3 years is typically what we look at. But there's some exceptions to the rule, but that's typically what we look at.
For emergency medicine, for our group, we had 1,700 applicants last year for 22 spots. So if you apply to our residency, you have a 1.8% chance of getting in. It sounds for you less than 1% chance of getting in. 2,000 applicants for 14 spots. So that's very, very competitive.
Yeah, I don't even get me started on the match and how that works. But that's a little bit further down the road for a lot of you guys. But there's a lot of issues with the match, and we can talk about that a different time. So I threw this slide in there because sometimes people ask me, well, what can you do with family medicine? And one of the things I like about family medicine is it is incredibly malleable as a career field. You can do a ton of things with it. I already mentioned to you, I'm in the military. I was in the military, and they loved us because we were comfortable taking care of patients in a clinic or on a flight line or in a tent. There were times when I was in the Air Force and I actually was sewing up scalp lacerations by flashlight in a tent. So that happened. We're very good to have on missions trips wherever you're going, because it doesn't matter the age of the patient or what their presenting condition is. If you're in Timbuktu, we can probably at least get started with it, whatever condition it is. I have a friend that went and got his MPH after he did his residency, and he's now working for the CDC in Atlanta, Georgia. So if that's your kind of thing too, if you want to do more population health epidemiology. I got a cruise ship in the picture because family docs make great doctors on board cruise ships and any kind of travel medicine type of stuff. Few years, well, actually more than a few years ago now, 10 years ago now, one of our faculty was vacationing down in Cancun, and her husband got sick, and they went to the concierge desk at the hotel and said, hey, might need to see a doctor. So they sent one up, and it was the family doctor that did hotel calls at the resort. So that's not bad. I have family docs friends that do nothing but urgent care, so that's why the care now symbol is there. And then there's something called locum tenens, which is basically just means temp work. Because there's a shortage of doctors, you can pick up temp work all different places. And I have friends that do nothing but temp work. They'll work for a couple of months, and then they'll take a break for a little while and then go somewhere else and work for a couple of months. The most sort of exotic example of this is I have a friend who actually did locum tenens all over the world, and pretty much he went, I think he did some locums in Australia. He's currently in Scotland. He's mainly based out of Scotland now, but he's also done some locums in Germany as well. So you can do that sort of thing. Tim Johnson, there's an ABC journalist down there in the lower left corner. He's not a family doc, I don't think, but he is a primary care guy. So I'm just saying, if you want to get into, medical journalism, that is a possibility to do from primary care. Got the prison bars to remind me of, there's a lot of primary care that needs to be done in our nation's prison system. And, there's an interesting patient population to be taken care of there. They get themselves into all sorts of trouble, and they need doctors just like everybody else. And interestingly enough, I've talked to people that worked at some of the local jails, and people that work at the jails generally feel safer because all the patients are cuffed and they're surveilled all the time. So it's
Dan, I did several years of institutional medicine when I went back home. The local jail was right across the street from my clinic. So I spent several years running the jail clinic, and it was really interesting. I would always ask the guys after I saw the inmates, typically male, why are you in here? And I had one guy, a big fella, came in and sat down. And I said, well, what's the problem today? He said, it's my back. And I said, okay. So I looked him over and I was writing a prescription. And I said, by the way, what are you in here for? He said, they say I did armed robbery. And I said, really? How many times? He said, 14. It was always kind of a jolly thing, that being involved in that, but they got to have care too, folks.
Yeah. I mean, it actually, it actually pays pretty well because there's sort of this stigma attached to it. People are like, I don't want to work in jail. Well, it's really not that bad. And it's a good deal. It's a little bit of a niche kind of thing.
And it's contract labor. You get a paycheck for doing it. You don't have to bill somebody.
Yeah. Yeah. Not having to deal with the paperwork not to be understated.
Dan, as an academic, do y'all get ranked in terms of the billing per chart that you do? We certainly do in emergency medicine. The term is called for the students the relative value units, which means what are you actually billing the patient? Did you just talk to them for a minute? It's a very small bill, or did you do a complicated evaluation? Do y'all get ranked on that? We do.
So our incentive plan is tied to RVU production. I'm sure our department chair knows who the big RVU producers are, but that is not made common knowledge among our department. But I can say that where it shows up clearly is going to be in your bank account because the incentive plan is tied to that.
Super. Keep rolling.
Yep. I got a little photo of Regina Benjamin there. She was a family doc and used to be the former Surgeon General of the United States. So if you want to get involved in administrative and leadership type things through family medicine, you can do that too. You don't have to be a neurosurgeon or anything like that. And then the last thing over here in the corner is a little picture of from a concierge medicine group. Concierge medicine is basically what I think of as executive medicine, right? So if you're a busy CEO of one of these big companies here in Dallas and you get sick, you don't want to go wait in the doctor's office. You don't have time for that. So you subscribe to one of these concierge medical services and you have the doctor come visit you. And there are family medicine docs that are doing that quite successfully. So those are just some options that kind of threw out there I can think of off the top of my head. So different things you can do with family medicine, and there's more than that out there. If you've seen one family medicine practice, you've seen exactly one family medicine practice, because there's all sorts of variations out there. You can really make this career what you want it to be. I've heard people say that, well, if you do family medicine, you can't do any fellowships. You're just kind of stuck. You're done. That is absolutely not true. You cannot do the same sorts of fellowships that you would do from internal medicine, right? So you can't go to be a cardiologist, or you can't go be a gastroenterologist or something like that. But on the list here are 21 different fellowship opportunities that you can do through family medicine. Not all of these are run by family medicine or owned by family medicine. But you can do all these. And Ray's probably already noticed down there on the list is emergency medicine services.
Absolutely. That's my world. And getting a fellowship in EMS, which is actually a subspecialty now, excuse me, in medical direction, can be approached from many venues, from emergency medicine, family medicine, surgery, internal medicine, and even pediatrics.
Yeah. So if you ever, have people say, well, you can't do any fellowships from family medicine, that is absolutely not true. In addition to that, some of these fellowships, as I'll show you on the next slide, actually result in something called a CAQ, or a Certificate of Added Qualification. It is basically, there's certain curriculum that has to be done in order to meet the CAQ requirements. It's regulated by the ACGME, which is the Accrediting Council of Graduate Medical Education. And at the end of your fellowship, you have to pass a standardized exam. And I've listed the ones on the side there to the right, all the ones that are CAQ or lead to a CAQ if you do that fellowship. And then some of them, the asterisk ones, are ones that aren't specifically owned by family medicine, but are certainly open and available to you from family medicine. And in case you want more information about that sort of thing, I put the link to the ABFM, American Board of Family Medicine website. All right. So this is kind of what a day looks like for me. And so this, when I say day in the life of a family doc, this is a day in the life of like me, like an academic family doc. But honestly, every day is different, even for me. And, depending on the practice, every family doctor you ask is going to have a slightly different day because of the difference in practices. We have a family doc who runs a direct primary care practice in town, and she works with some of our students, and her day is drastically different because, she only sees patients like in person in clinic. She probably sees on the average of 4 or 5 patients a day. And the rest of the time she's fielding phone calls from patients or emails from patients or doing telehealth visits with patients. So her day looks a lot different than mine. And as I mentioned, even for me, it depends on kind of what I'm doing. Sometimes I'm slated to attend on our inpatient service at Parkland or at Presbyterian, where I'm going to be in the hospital every day. And other days I have, meetings that I'm slated to go to, and I might have administrative time to go to these meetings and stuff like that. So, yeah.
Would you say that COVID has at least impacted some of an increase, shall we say, in telemedicine activities in your department?
Oh yeah, absolutely. I think that's a big topic for the House of Medicine as a whole right now, is how are we going to handle telemedicine? The biggest way that you see telemedicine impacting primary care in our clinic right now is a lot of the behavioral health care is delivered through telehealth, because there's really not a lot of physical exam to be done on a patient that has, let's say depression or anxiety that you're treating. Most of your physical exam can be done simply by observing the patient in their affect and things of that nature. And you can manage their medicines as well remotely. So I think at least, well, especially in the realm of primary care mental health, I think telehealth is here to stay. I don't think it's going anywhere. Obviously,
I think the question is how we in medicine are able to provide the resources that can be part of that, Dan. And for example, you gave the Freestyle Libre. I'm not putting out a brand there, but it happens to be one brand of monitoring glucose levels, and then it talks to the cell phone, and the cell phone can actually populate your medical record. I mean, that's terrific. But other things, weight, blood pressure. I'm about to do a study for the students. Bariatric means very heavy patients. We're working on a bariatric protocol for EMS pre-hospital here in North Texas right now, for example. Go ahead.
No, I think that's awesome stuff. And I don't think telehealth in all its varieties is going away by any means. And that technological interface is amazing. Where we have to be careful is making sure that patients still feel like they have a doctor that's in control of all that stuff. I don't think, or at least I could be wrong, but I don't think very many people are going to feel comfortable with a sort of an AI as their physician, right? We could probably program some AIs to, manage diabetes based on blood sugar information and that sort of stuff. But you still want a doctor there at the end of the day.
Yeah, what's AI gonna say of the diabetic who weighs 350 pounds? You need to lose weight. Well, they got to come to you and get dietary counseling and get on their 1,500 calorie American Diabetic Association diet and be counseled about that and have periodic weigh-ins and so forth. I mean, AI can help, but I don't think it's going to be the be all,
Yeah.
for the future.
Not only that, you may find that this morbidly obese patient that you mentioned is severely depressed, and they're not going to be motivated to do squat until you address that depression.
Absolutely. Good stuff. Keep rolling.
Yeah, we're getting close here, but this is just sort of what's a typical week like in is your average primary care family practice clinic. What sorts of patients do you see? And you can see kind of the general distribution down there in terms of how many new problems are seen starting at the bottom versus chronic routine problems like diabetes versus I'm here for my annual physical kind of preventive care stuff, and kind of on up the slides. So, our kind of patient distribution sort of resembles, internal medicine a little bit. What you can see is that the internal medicine guys in red have the slightly more chronic routine problems, whereas family medicine has the slightly more of the kind of the new undifferentiated problems. And we get that all the time, right? Patients come in with some symptom that needs to be fully evaluated, just like happens in the ER. Someone comes in with a cough, or they come in with shortness of breath or chest pain. That happens in the primary care office. Hopefully, it's just not as of an acute nature as what happens in the ER. So here's my case example for this. Got a 50-year-old guy who comes in for an annual physical exam, doesn't have any concerns. His only past history is some high cholesterol and allergies. He's been following a ketogenic diet because he wants to lose weight, and he's concerned about his cholesterol. He's been physically active, trying to get in shape, runs 3 miles 3 times a week. And he says, during the exam or during the history, sometimes I feel dizzy at the end of my run, or if I stand up too quickly, which is, generally pretty benign kind of symptom. And he's had some symptoms of feeling bad for the past couple of years. Social history's pretty clean guy there. He's a pastor. He's married with 2 kids, no drugs, no alcohol. On physical exam, you listen to his heart, and it is irregularly irregular, with no murmurs, gallops, or rubs. Anybody got any ideas what that means? What the diagnosis is?
Let's hear it, folks. Speak up. What is it? Irregularly irregular. We've talked about this a little bit. I think Daniel nailed it. He said AFib. Does he get an A, Dan?
A+, absolutely. Yeah. So yeah, sure enough, we get the EKG. He's an AFib with a rapid ventricular rate of 123 beats a minute. So this can potentially be a condition which you have to send the patient to the ER for. But he was looking very stable in front of me. So I put him on a little metoprolol. I called the cardiologist and said, hey, what do you think? Can you see him tomorrow, or should I send him to the ER? And the cardiologist is like, no, I'll see him tomorrow. So we managed to get him a cardiology appointment the next day, save an ER visit for Ray, and put him on medication management for a few months. Eventually, he transitioned and underwent ablation, which meant he had it's sort of an aberrant electrical pathway that had to be kind of burnt out. And this was a guy that would just come in for an annual physical, and I just happened to diagnose his AFib just by listening to his heart there. He was very grateful, and now I'm the physician for his entire family. And, hey, that's a cool thing.
My dad, he's passed now. He lived to 83. He was in atrial fib for at least the last decade of his life, rate controlled on digoxin. And we'd go over there and he'd have a nice slow heart rate. He would swear that his heart was just fine, and it was nice and slow, but it was irregularly irregular.
Yeah. And that sort of things happened to me a couple times. People come in for just a routine physical, and you're just like, how are you sitting here? Like you're in a full on AFib and RVR, and you're just sitting here happy as a clam. I don't know how that happens.
It's also pretty common. 5 or 10% of people, especially as they get older, are going to have AFib. We see it all the time.
Yeah, true.
I had an AFib RVR come in over the weekend. That's rapid ventricular response, folks.
Yep. So, what's life like for a family doc? You guys know, you've seen all the little things that rank, family medicine and how much we make a year and all that kind of stuff. We're always, we're down there with the pediatricians and the GIM guys, in terms of general internal medicine guys, in terms of lowest paid and all that kind of stuff. But does life suck for me? Absolutely not. So, the average family doc spends 68% of their time in direct patient care, which I love taking care of patients. So that's great. If you're doing sort of patient care every day of the week, you're going to see roughly 89 patients a week. I do get weeks, time off for vacation and CME. And here's the mean income for 2020. Hey, 232 is not too bad, really. And so the question is, what can you do with $232,000 a year? Well, here's my family. We've been all over the world and all these kinds of things.
I rode a camel in Egypt one time. That was the nastiest animal I could.
That was in Morocco.
Was it?
Yeah, they were awesome. They were okay. That was docile. These are two of the cars that I have. So I didn't buy them right after residency. It took me a little while to get where I am, where I could afford those. But I have some nice cars.
Did you buy them new or did you buy them used?
Oh, come on, Ray. I call them my used cars.
I drive a 16-year-old Mercedes that I bought with 80,000 miles on it, and I love my car.
Yeah. If you look, so I'm technically a state employee, right? We all are, right, Ray? So
sure.
You could say, if you want to look at it in a negative light, you could say I'm a lowly paid state employee that drives used cars. You could say that.
Now, I do remember what I bought in my 40s, which was a 928 Porsche. And I knew how fast that would go. I'm now the slowest person driving on the street these days.
928s are nice.
Oh, it was a rock and roll car. Okay.
Anyways, so can you get a job? It is absolutely easy to get a job as a family medicine doc. You can pretty much get a job anywhere across the country and even internationally as well, as I mentioned to you before. So, if you have some geographic issues that you need to work through, or you have a spouse who needs to move frequently, family medicine's or primary care is a good field to be in because it's easy to get a job no matter where you end up. And then I got this in the mail a couple of years ago, and I just throw it out there. You kind of see what a job offer looks like coming straight out of residency for family medicine. This one's a $300K base salary with $30,000 signing bonus. And it's student loan repayment offered. And that's pretty much it for me. If you want have additional questions about family medicine that I didn't answer for you tonight, you can go to this website here that's on the slide. And then this is just a picture of me with some of my college's students. These guys are my MS4s that are actually in the process of applying to residency right now.
Dan, thank you so much. Gosh, you've been going almost 2 hours. God bless you. Need a sip of water or anything?
I'm about done. I had a glass full. Now I'm about done. So,
well, you got time for maybe 2 more questions?
Sure, no problem.
Cheyenne, take it away.
All right. Well, thank you so much for your presentation. That was very captivating, and so great information for all of us. I think that one of the major questions I think that a lot of students can relate, for those of us who love teaching, particularly educating patients, do you have any suggestions for us as far as specialties to pursue goes?
So, yeah, I mean, if you like educating patients, then you definitely want to stick in the primary care realm. because that's what primary care does. Whether it be general internal medicine, general peds, or family medicine, we spend a lot of time talking to patients about just how to keep themselves healthy, diet, exercise, all that stuff. It's critically important. I'm a firm believer that movement is medicine, right? And so you got to motivate people, get them going.
That's right. And so how do you stay up to date on developments in medicine and prevent forgetting how to perform such a wide range of procedures?
That's a great question.
Yeah. So I think, at least for me, as far as procedures go, being a part of a residency is really important because we're tasked with training our residents to do all these procedures, and so we've designed rotational experiences so that we get those procedures and we train the residents how to do them. So I'm always teaching my residents how to do those things, which keeps me up to date and not getting rusty. I think if I were in a different clinic situation where I decided I wasn't going to do any procedures, I probably would get really rusty. And you do see that sometimes. You see doctors that have decided that, for a number of years, they're just not going to do procedures anymore. And yeah, then it's hard to come back from that.
Another way is, of course, you attend meetings. Here at the university, we have meetings all the time. Thursday mornings are our residency conference, where we're always inviting the pro on some area to come, the real smart dude, to come over and present to us on the current aspects of how things are. I also, like I'm sure Dan does, I've got so many emails that pop into my inbox with the Journal of the American Medical Association, the New England Journal, and many other things with the new current stuff that's out there. And then, of course, in the clinical practice, when you're around really smart residents and students who are studying all the time, you get probed questions all the time that, keep you right on the edge of your knowledge base. Don't you think, Dan?
Yeah, no, absolutely. And, from a procedure standpoint, there's always, just like there's new medical knowledge coming out, there's new stuff from a procedural standpoint coming out all the time as well. When I was a medical student, an ultrasound machine was literally the size of a car and cost like $200,000, and the radiologist would not let you get anywhere near the ultrasound machine, right? And so fast forward, now we have this thing called a butterfly, which you can slip into your pocket and it plugs into your cell phone, and you can do an ultrasound with the butterfly at the bedside. So, those of us that have been around, do we have to learn new procedural skills? Yes, absolutely. Do I have to take a class or a course sometimes specifically for how to do that? Yes, absolutely.
What I would add to that about ultrasound in my world is that I was cutting up bodies in the early 70s in the anatomy lab. And now here I am 48 years later, having to remember 4-dimensional anatomy. It's not just 3-dimensional, but you're looking in the heart and the heart is moving. And so I'm encouraged about the fact that the stuff I learned as a student is still applicable nearly a half century later, Dan.
Yeah.
I will finish up with this one last question here, and I'll let you go, so I don't want to keep you too long. So this last question, I feel like a lot of students might be wondering is, do you find that patients are often disappearing from your roster rather than the good old days when there was more closeness to your patients throughout their lives?
Say that again, that they are more what?
The question was that, do you find that patients are often disappearing from your roster rather than, back in the day when there was more closeness to your patients throughout their lives? I guess they're asking.
Yeah, I read that question. Are your patients drifting away sometimes, Dan?
Oh, well, yeah, there are some patients that do drift away or disappear, if you want to call it that. And that's for a variety of different reasons. Sometimes it is the patient doesn't feel like they developed the sort of rapport or chemistry with the physician that they would like to have, so they find somebody different. That does happen. I like to think I'm a pretty easygoing guy and get along with just about everybody, but honestly, there's been times where patients were like, I don't like you. Okay, that's okay. I'm not for everybody. Sometimes, patients drift away for other reasons, because of their jobs. They move, or maybe they lose insurance and they can't come see you anymore.
Or their
Um,
insurance changes.
yeah, yep, exactly. So there's any number of reasons why patients may end up drifting away from you. I've amazingly had some come back too, like, after they were out for, they drifted away for whatever reason for a few years, and then they're like, well, now my insurance changed, now I'm back, and I'm like, well, that's awesome. I'm glad to see you again. Catch me up on what's been happening for the last few years. Um, but yeah, it's an unfortunate situation. It does happen because we don't have the same sort of, um, our culture isn't the same as it was back in 1948, right?
Well, Dan Septim, I just want to say thank you so much. I'm going to ask all of the 140 students still online with us to please put "thank you, Dr. Septim" into the chat so you can see how very much we appreciate you coming. Dan, this means a great deal to us, and your skill, your grace, your wonderful demeanor, how much you've committed your life to the service of others just means so much to all of us. Dan, we'll be posting this talk of yours online, and typically around 5,000 people, pre-health students, will watch it. Each one of those will become a healthcare provider and will see perhaps 100,000 visits in a career. That's very reasonable. 5,000 times 100,000 is 500 million. Dan Septim, tonight you've touched 500 million lives with your
Thanks, Ray.
wonderful story of what you've done, your career, and sharing your time and your family with us. So we're just so very, very grateful. Cheyenne, do you want to tell us about what this funny looking thing is here on this slide?
Of course. So this is the QR code for Assessment 80. Assessment 80 will be due next Tuesday, December 7th at 6:59 p.m. Central Standard Time. And so please, upon passing with a 70% or higher on this assessment, please download the certificate for your record, as that will be your only option to do so at that point. And so that is everything regarding the assessment.
Well, on behalf of the whole virtual shadowing team, we want to thank you for coming. It means a great deal week after week that you come and be with us. This, our 80th lecture that we put online. I know that Dan would share with you the fact on the admissions committee, we look to see at least the student should have 50 or more hours of some kind of shadowing time. Well, folks, with 80 lectures and 2 hours per lecture, there's 160 shadowing hours out there for you. So don't come back whining that you couldn't find shadowing time, because we put that out there for you at no cost. We're so glad you're coming week after week. I know on behalf of Cheyenne, the whole virtual shadowing team, and our wonderful speaker tonight, Dr. Septim, we want to thank you for coming. We wish you a good evening and a good night. Thank you.
Good night.